year. So we're going to start with Jenna Tate from Leeds. She's going to talk to us about the perceptions of frailty and how frailty is assessed in patients living with myeloma.
Good morning, everyone. And if I could start by thanking the UK Myeloma Society and Johnson & Johnson for supporting me to be able to attend IMS this year. My session is much less scientific than all the other sessions that you're going to hear today, but also equally quite important and quite a hot topic. So I'm going to talk to you about a project that's forming part of a much larger piece of work in Leeds around frailty in myeloma. These are my disclosures and my role, so I'm not a doctor like everybody else speaking today. I'm the lead advanced clinical practitioner for oncology and haematology in Leeds, and I work clinically within the myeloma team. We all know that we have a rapidly ageing population. People are living longer and longer. And inevitably, with that, we're seeing more comorbidities, we're seeing polypharmacy, we're seeing overall global declines in condition. But when we're thinking about frailty and we're thinking about the various frailty tools that are in existence and how we assess frailty, we need to think beyond age. Now, we've all met those patients that are in their 40s that are not really fit for much. And we've all met those patients in their 80s that could probably sprint out of this room quicker than quite a lot of us in here. And I shamelessly stole a fact from Professor Gordon Cook, one of my favourite facts I've heard this year. And it was at the Taiwanese athletics this year. A gentleman that was 105 years old won 4 gold medals. It's pretty impressive, isn't it? It's less impressive when you hear that he was the only person in that category, but still, a win's a win, isn't it? A win's a win. But what was lacking, so we're doing a lot of work around frailty, just like everybody is, but when we looked at the literature, there was lots of studies around comparisons of frailty tools, around dose reductions and how that looks. But what was really, really lacking actually was patient perceptions of frailty. Do they understand what frailty is? Do they know how we assess it? What are their views on how we assess it, and should it be done any differently? And with that in mind, we've done a very small study, a small patient focus group that we applied for and successfully had a grant awarded for. Just 9 patients via open recruitment, and we did that through myeloma support groups, and we did it through outpatient and inpatient recruitment. And the aim was to explore what their perceptions of frailty are, to have a look at the frailty assessment tools that we use in practice, and also to give consideration to whether or not there is a better way to assess frailty, mainly thinking about the use of medtech. Before we spoke to the patients, the participants, about what frailty was, so they weren't given any definitions of frailty, we didn't give them any of the tools, we didn't talk about the tools, we just asked them that question. So, do they consider themselves frail? And pre-diagnosis, none of them considered themselves frail. But at the present moment in time, we had 4 that felt they were frail, and 2 that felt they weren't, and 2 that were unsure. And what's important to add there is that all of these participants were at very, very different stages in their journey. So we had some that were on active treatment, some in trials, some just post-autographed, some that we were just watching and waiting. So then we asked them, we put them into groups and we asked them to explore what they thought frailty was. What does it mean to them? What do they think it is made up of? And we were able to put that into 4 themes of physical restrictions, psychological well-being, social impact, and treatment-related issues. But my reason for using the word cloud is just because I think they're quite powerful in terms of, and I think that's the nurse in me, likes to really put across the key points. And what I found was really, really interesting was that a lot of them talked about it being a spectrum, and that actually, in terms of frailty, it would depend on the day that they were asked. For example, dexamethasone day, they might feel a little bit different. Breaks in cycle, they might feel a little bit different. So then we talked them through IMWG, which you'll all be familiar with, and G8. G8 is a geriatric score that it's not about adjusting treatment, it's about saying whether or not somebody needs further geriatric evaluation. And we sat and we talked through the scores, and we allowed them to score themselves based on the information that they had. And of those that completed, there was only one who didn't. 3 were frail on IMWG and 6 were intermediate fitness. And all of them that completed would have required full geriatric evaluation. And they were quite shocked by that feedback, actually. And we asked them to reflect on how they felt about that, how they felt about the tools, and how they felt about what the tools had highlighted in terms of their level of fitness. And the nurse in me, again, finds it very difficult to see the word not human, because as nurses and as medics and as all of us in healthcare, we're taught to be holistic, we're taught to be individualised, we're taught to be patient-centred. So to have the feedback that it's not individualised, that it's just a set of numbers, that it's just a tick box exercise is quite harsh, really, isn't it? It hits quite hard. They also fed back that they felt it would be variable depending on who completed the tool. For example, if a consultant that has known them for a long time and seen them many, many times in clinic over many years and many lines of treatment was to complete the tool, they felt that it would be more accurate than somebody seeing them for the first time in clinic. We briefly explored medical technology, and what was very interesting was that for some of them, the feedback that was positive or the thoughts that were positive were negative for the others. So, for example, quite a few of them said, well, I like the idea that I wouldn't have to attend hospital quite as much. Other people said, I don't like the idea that I wouldn't attend hospital as much because I value that time in clinic. I really value being able to ask questions. One person said they wouldn't want it to look like an ASBO tag. Would it go with a ball gown was a very interesting question. And one patient said, I wouldn't want to wear it when I was unwell, and you're kind of like, oh, that defeats the whole object, really. But it was really interesting to get that feedback, and that's something that we want to look at in a lot more detail. So my apologies, I only had 5 minutes for this, so it is a very quick whistle-stop tour of what we've done so far. But what we've learned from what we've done so far is that do we need to think about phraseology, because frailty was actually quite an emotive term in terms of negative connotations with the word from the feedback that we got from the patients. We need to look at this a bit more because there's lots of misapprehensions about what the patients feel frail is versus what we feel frail is. And is there a better way to assess frailty? And I'd like to thank Professor Cook and the team at Leeds who've supported me with this work. And again, the UKMS and Johnson & Johnson for supporting me to travel to IMS. Thank you.
Fantastic. Are there any questions that Jenna? Perhaps I'll ask a quick question. Do you have a feeling for the difference between using these tools in a trial versus standard of care? So I guess your feedback is suggesting that maybe in standard of care it's not helpful for patients to hear this, but is it, I guess we still need to categorise patients to do the frailty studies that
Absolutely.
Professor Cook is leading. So
I think you make a very good point, and it's something that we've considered in part of the larger piece of work that we're doing. In terms of the patients that we saw, again, they were all at very, very different stages, but their perceptions may be different to somebody who's a brand new diagnosis as well, for example. So I think there's definitely a larger piece of work that needs to be done, and we're not there yet.
Fantastic. Thank you. Sorry, Sally, very quick question, then we have to move on.
You can't have questions, you've heard this before.
Great talk, thanks so much, Jenna. Just wondering, what do you propose in terms of phraseology? What would be better than frail and otherwise? And did you explore that?
We talked about, so myself and Gordon have actually talked about this, and it's really difficult, isn't it? Because any word that you kind of use to indicate frail is very, it implies something negative. We talked about treatment vulnerable as a potential term. But again, vulnerable is a term that you could associate with negatively. So I think it's really, really difficult, actually. What we are going to do is another patient focus group, and that's something we're going to explore with the patients. So they're the important people in all this, and I think it's important to hear their feedback and what do they think? Do they have any suggestions? And then we can kind of look at that.
Fantastic. Thank you very much, Jenna.
Thank you.
Okay, so our next speaker is Alice Feast from University College London Hospitals, who's going to talk to us about CMV monitoring and management.
Hello. Thank you very much to the UKMS for funding my travel to IMS this year. So I'm going to just talk about a project that we've done locally, looking at the monitoring management of CMV and other viral reactivations in patients we have on bispecific antibodies. So the reason why we did this project is because we know that CMV and other viral reactivations have been reported in the trials of the bispecific antibodies in these patients. But there isn't really like a clear guideline as to how to monitor or how to treat these patients, which means that actually there's quite a lot of variation in terms of what people are doing, including within our own centre. And this isn't my slide, but this is just showing, this is from the IMWG guidelines supplements. They asked, I think, 50 people on the immunotherapy subcommittee what they would do in terms of managing CMV. And you can see that there's like huge variation basically in terms of what even the members of that committee were saying in terms of monitoring and how they would react if they had a positive CMV PCR, which is what the bit on the right is, in the absence of any obvious CMV disease. So that's the context. Next slide. So what we did was we looked back just within our own centre, which is UCLH, and we had 99 patients, all with a diagnosis of relapsed refractory multiple myeloma, and we included anyone who'd completed at least one or more cycles of teclistamab, elranatamab, or talquetamab between January 22 and May of this year. And we basically just went back through the medical records to obtain the results. So this is just a kind of breakdown of what the population looked like. So you can see the majority of patients were on a BCMA-targeted bispecific and a small minority on talquetamab. So demographics, so median age was 65, median duration of treatment 6 months, and median follow-up 11 months. Looking back through all the patients, at least half had received IVIG replacement at any point since starting the bispecific, and about half had also had at least one dose of GCSF at any point. So in terms of how heavily pretreated these patients were, so the median number of prior lines was 5, and you can see the very vast majority had had at least a PI and an IMiD. A large number had had at least one stem cell autograft, so 89%. 24% had actually had 2 autos, and 4 patients had had an auto and an allo, or 1 patient had had just an allo of those 4. So heavily pretreated population. So looking at the practice in terms of what we were actually doing, so about 78% of our patients had had CMV serology checked at baseline before starting. And I would say that was quite a wide baseline, so it wasn't necessarily the day before, it was just within the year before starting, of whom 55% were positive for CMV IgG, 45% negative. So CMV testing of these patients during treatment was very variable. So a quarter had never been tested for CMV with a PCR at any point while they were on treatment. About 20% had only had 1, and just over half had had more than 1 CMV PCR. So the median number of CMV tests per patient out of our population was just 2. So you can see it's with a range of 0 to 21, so it's very variable what people are doing. So these were our results. So this was specifically looking at the patients who were on the BCMA-targeted bispecifics. So 60 patients had actually had their CMV PCR tested. 36 of them just had negative PCRs, and 24 had 1 or more positive PCR. So of those people with positive PCRs, 13% had a viral load that was equal to BLQ, which is below the limit of quantification. So it means it's positive, but we couldn't put a number on it with the tests that we use. And then 11 had a viral load that was above the lower limit of quantification. And actually none of these positive patients had any clear CMV disease, was the finding. So in terms of the patients who did have positive tests, how had they been treated? So 21 patients had continued on treatment, and everyone who continued had continued to have low CMV levels or actually had spontaneous reductions in the titers despite ongoing treatment. But you can see that actually of these patients, the median viral load was very low. So the median viral load was below the limit of quantification, with a relatively low range. And then 3 patients had had higher levels. So the median peak viral load in these patients was 57,980. and they'd had interruptions in their treatment. So it was a median of 97 days interruption, and all of those patients we'd seen a decrease in the viral load of CMV without any loss of response in terms of their myeloma parameters. So this is just looking at the patients who continued bispecific antibody treatment without interrupting, and it's just to, I guess, show you that the vast majority, so this is all of the swabs that were done, the vast majority of them were actually below the limit of quantification or very low level, so less than 1,000 in terms of the copies per mil of the viral load. So this was just looking at the frequency of how often they were getting the bispecific antibody at the time that they were first positive. So the vast majority, you can see, it was kind of early on, so they were having weekly treatment, but it also occurred in patients who were having bi-weekly or even 4-weekly treatment. And this probably won't surprise anybody, but all the viral reactivations we saw were in people who are IgG seropositive pre-treatment. So we looked at some risk factors for CMV reactivation to see if we could find anything obvious, and it was unrelated to age, number of prior lines of treatment, baseline lymphocyte count, nadir lymphocyte count, previous T-cell immunotherapy, nadir IgG level, or use of IVIG. So basically there was nothing in particular that seemed to be an extra risk factor. So this is just looking at other viral reactivations. So generally these were asymptomatic. So in the patients who were on BCMA-targeted bispecifics, there were a couple of cases of adenovirus, some EBV, and the only symptomatic patient actually had a reactivation of parvovirus and ended up being treated with IVIG for that. And then looking at the talquetamab patients, they also had some asymptomatic viral infections. So 2 of them had a below limit of quantification CMV titer, and 1 had EBV, again without any symptoms. So we looked at the survival curve for people who had CMV positive PCR versus the negative, and yeah, basically there was no difference. So conclusions. So CMV reactivation is common in patients on the BCMA bispecific antibodies in our population, seem to occur quite early in treatment and generally with a very low viral load, which was often below the limit of quantification in our data. Actual CMV disease in our data was rare, so none of our patients had overt CMV disease. Non-CMV viral reactivations in our data were also rare, and except for the person with parvovirus, were all asymptomatic. And our feeling was that the data doesn't clearly support sort of routine CMV monitoring, but would like to point out that it was a single center analysis, and as you can see from what we presented, there's no kind of uniform PCR testing monitoring going on at the time. So yeah, thank you again.
Questions? Paula?
Yes. I was wondering, when you showed below quantification or less than 1,000 patients, when they were below 1,000, were treated again with the bispecific, or you all therapy until they went below quantification?
Yeah, so that group of patients discontinued treatment. So all of those patients on that slide, they were the 21 who continued treatment without interruptions. They continued to get bispecific antibody treatment.
Yeah, because in our end too, sometimes they never become negative, so even less than 1,000 are still safe to restart.
Yeah, thank you, Alice. Very nice. Have you actually looked at your normal myeloma patients on treatment and CMV reactivation? Because sometimes we mistakenly did CMV and then we saw reactivation, and basically we did nothing.
You mean patients not on bispecific antibodies?
Not on bispecific.
Yeah, we haven't looked at that, but that would be very interesting. Okay.
Sure. Thank you.
Okay, we should probably move on for the sake of time. So thank you very much. That was brilliant.
Thank you. The next IMS Abstract Award winner is Dr. Amata Mirandari from UCL. She's going to talk about investigating the role of BAFF-APRIL system in promoting progression of smoldering myeloma.
Hi, yeah, thank you so much for having me, and of course the UKMS for the opportunity to go to IMS. Today I'll be talking about our project, which revolves around investigating the BAFF-APRIL system in progression of smoldering myeloma. So I'm sure BCMA and friends are not everyone knows kind of about it. Essentially, it is a system that involves 2 ligands, APRIL and BAFF, and 3 receptors, all of which have been found to be elevated in myeloma patients, resulting in activation of downstream pathways, including NF-kappa beta, making them an important signaling system for the survival of myeloma cells. The aim of my project was kind of to see how this system is modulated across progression from smoldering to myeloma, of which is less understood. And to do this, I firstly focus on a bioinformatics approach using our integrated single cell atlas that was previously put together by a PhD student in the lab to look at how these changes happen on a transcriptome level, but also supplementing by understanding on the protein level what actually happens through ELISA and immunophenotyping. And of course, we rely on 2 of our clinical studies, Cosmos and Radar, for our patient samples. So firstly, focusing on the transcriptome and kind of looking at these 3 cell types as they are the main players in the system, we first confirmed that BCMA and TACI are mostly expressed by plasma cells, while BAFF-R is mostly restricted to memory B cells. And in terms of ligand expression, as has been shown before, both BAFF and APRIL are mainly expressed by myeloid cells, which include monocytes and dendritic cells. I used a tool called CellChat, which is a bioinformatics tool for single-cell data to look at what kind of ligand-receptor interactions change across disease, so between smoldering and myeloma. And interestingly, BAFF signaling was one that came as significant and is greatly increased in myeloma compared to smoldering. So what does this look like? So if we look at specific cell types involved in the signaling system, interestingly, in healthy donor, while we see that most of the signaling is being received by the B memory cells, as you progress across disease in myeloma and smoldering, you find that most of the signaling actually is now reverted to being taken up by plasma cells. And likely this is due to the accumulation of these malignant plasma cells in the bone marrow as disease progresses. But in addition to this, we also see that other myeloid subtypes are getting involved in the signaling, which includes dendritic cells and macrophages being signal senders through this BAFF system, which we don't see in smoldering. And in terms of the ligand receptor pairs themselves, we see that there's a shift from predominant signaling of BAFF to BAFF-R to actually BCMA in the myeloma stage. So likely this is driven by intrinsic changes in the tumors themselves. You can see here that receptor expression on the transcript level actually increases between myeloma and smoldering. And these changes are not individual, but they also correlate with between ligand and between different receptors. For example, TACI and BCMA are positively and significantly correlated in malignant plasma cells. And expression of BAFF and monocytes increase as your level of BCMA increases in malignant plasma cells. What happens on the protein level? So we did ELISA on plasma of smoldering and myeloma patients. So similar to that we see in transcript, soluble levels of BCMA TACI also increase. But in terms of ligand levels, we actually find that both APRIL and BAFF drop in myeloma compared to smoldering. And one explanation for this would be that the greater amount of receptors available on the actual myeloma cells themselves, as well as in plasma, would result in the sequestration or increased kind of take-up of these ligands. So the measurable pool at the point of myeloma is much lower. So what happens downstream of this signaling? So as I mentioned before, NF-kappa beta and survival mechanisms are increased as a result of increased BAFF signaling. So we see here again, I scored NF-kappa beta activation, and that is elevated in myeloma compared to smoldering. And this also, you see that there is increased survival gene expression, including MCL1 and BCL2A1 in myeloma. And this is associated with the increase in NF-kappa beta activation, and similar to that seen in BCMA expression as well. So finally, looking at immunophenotyping our myeloid cells, which are the main expressors of BAFF, wanted to see how this changes across progression and how this changes across the different subtypes. And unsurprisingly, not only do the frequency of BAFF expressors increase across all the myeloid subtypes, but they actually also increase a greater level of BAFF overall in myeloma compared to smoldering, with the CD16 monocytes showing kind of the greatest delta change across that progression. So a few conclusions, I'll just put them all there for you to read. We know that BAFF signaling is significantly stronger in myeloma. This is involved with a signaling shift from different receptors. Downstream, we find that survival signals increase as a result, or it's correlated with this. In terms of ligand levels, actually they drop in myeloma compared to precursor due to the likely uptake of more of them. And overall, there is a myeloid PC dynamic change where more subtypes get involved in the signaling, kind of highlighting how the BAFF-APRIL system is regulating and modulating and important in progression to myeloma. Just like to thank everyone who has been involved in this project. And again, thank you for UKMS for allowing me to travel to Toronto this year. Thank you.
Thank you. Any questions for Dr. Mirandari?
Just one quick one. Did you look also the fact your BAF on the soluble BCMA? There is any correlation with the amount of BCMA in the plasma, so soluble?
Sorry, between so the BAF and the soluble levels. Because I haven't really looked at whether the correlations are in the same patients. Kind of, there is a correlation, but I can look at that. I haven't done direct correlations between transcript levels and soluble levels either, but that's something I will look at. Yeah.
Any other questions? Checking for any online questions. None. Okay, if not, thank you very much. Great presentation. So the next IMS Abstract Award winner is Dr. Devi Nandana from the University of Oxford. Devi is going to talk to us about anti-adhesion properties of KTX-1001. There is actually some data oral presentation at ASH this year, which is a selective NSD2 MMSET inhibitor, enhanced carfilzomib sensitivity in multiple myeloma. Over to you, Devi.
Hello, good morning. I'm Devi Nandana from Oxford Translational Myeloma Center, and I'll be talking about the anti-adhesion properties of KTX-1001, a selective NSD2 inhibitor in enhancing carfilzomib sensitivity in multiple myeloma. First of all, thanks to UKMS and Sanofi for the IMS award and for this opportunity. Starting with a brief introduction, NSD2 is a histone lysin methyltransferase that catalyzes the H3K36 dimethylation. It is overexpressed in T414 myeloma, and that leads to global epigenetic reprogramming and transcriptional activation of oncogenic pathways. KTX-1001 is a selective NSD2 catalytic inhibitor, which is currently in phase 1 clinical trial in RRMM. So to study the mechanism of KTX-1001, we chose KMS11 cell lines, which are semi-adherent, T414, and NSD2 high. So when these cells were treated with KTX, we could see a striking reduction in the number of adherent cell population. As you can see here, these are the adherent cells after removal of the suspension cells completely. So these are the microscopic image of the adherent cell population, and there was a significant reduction in the adherent cell population. This is not merely a cytotoxicity because KTX on its own did not affect the total cell viability of KMS11 cells. However, there was a significant reduction in the colony forming efficiency of these cells. In a separate matrigel experiment, we also noticed that there is an increase in suspension cell population over 7 days and 11 days period after treatment with KTX. So when these suspension cells, after 7 days of KTX treatment, were analyzed for RNA sequencing, we noticed that multiple adhesion pathway-related genes are being downregulated in a dose-dependent manner after KTX treatment. Specifically, CD44, CD56, JAM2, and N-cadherin were significantly downregulated after KTX treatment. We confirmed this with Western blot. Consistent with the role of KTX, there was a drop in K36 dimethylation levels, and there was a drop in N-cadherin and CD56 levels as well. Now, given all these preclinical evidence, in the clinical trial as well, like 5 out of 8 patients after KTX treatment had a drop in CD44 levels. Like consistent with the role of KTX, there was a drop in K36 dimethylation levels in all the patients, and 5 out of 8 patients had a downregulation of CD44. Now, to understand the functional role of this cell adhesion effect, we tried to separately culture the suspension and adherent cells of KMS11 in the presence of carfilzomib. And it was noticed that the suspension cells are significantly more sensitive to carfilzomib compared to the adherent cells. So consistent with all these, there was a significant synergy between KTX and carfilzomib in a PI-resistant cell line, the KMS11 BTZ resistant cell line. There was a significant synergy between carfilzomib and KTX. So to summarize, NSD2 is being inhibited by KTX, which leads to a downregulation of K36 dimethylation levels, which then further leads to an epigenetic silencing of many of the adhesion markers. We all know about the cell adhesion-mediated drug resistance. So we hypothesized that the treatment with KTX is disrupting cell adhesion and probably dislodging the cells from the bone marrow, making it more susceptible to more cytotoxic agents such as carfilzomib. We are trying to evaluate this with other cytotoxic agents as well. This is quite an ongoing project. We are currently, I'm not going into detail of the future directions, but we are currently doing some RNA sequencing analysis to further elucidate what exactly is the mechanism behind the cell adhesion-mediated sensitization, and also doing some cytoprofiling on clinical samples to understand the mechanism further. I would like to thank my group in OTMC for all their support and guidance, specifically Professor Anjan Thakurta for his support and supervision. I would also like to thank UKMS and Sanofi for this IMS award and for this opportunity to talk. Thank you so much. I'm happy to take your questions. Thank you.
Oui.
The effect of adhesion on survival is considered to be mediated by the anti-apoptotic pathway, amongst the pathways.
Yeah.
Did you look at upregulation of MCL1?
Not
Alex
yet,
L.
but this is something that after the RNA sequencing, like we have plans to look.
Talking to the microphone.
Sorry. Sorry, we haven't looked at it yet, but we have plans to look at it actually, based on the RNA sequencing data. Yeah, sure.
Thank you. Am I allowed another?
Oh, okay. Quick, yeah, you've
One
got
more
the
quick question.
Yes.
Did you look at any differences between the cells that remained in suspension and the ones that were adherent? Does this separate subclones that are more susceptible? Is there a difference between them? Did you?
So basically, if you mean the proliferation rate or like the basic changes or
transcriptomic changes?
So they don't really have a difference in like proliferation rate, or like I have just checked all those things, but like there was no difference between them. But rather, like they are more sensitive to PI treatment. We also try to pre-treat the cells with KTX, and so there would be a natural population of suspension cells, whereas there would be a forced population of KTX-treated suspension cells. I didn't go through the results because of time limit, but then we have noticed that these suspension cells, which are pre-treated with KTX, they are more sensitive to carfilzomib. So we definitely need to look at the mechanism behind this, but yeah.
Selena?
Thank you, lovely talk. So I just wanted to ask, you said that you've tested PIs. Is it just carfilzomib, or have you tried other proteasome inhibitors as well? Sorry. That's my first question.
So we have seen that bortezomib is also having a synergy with KTX, but we haven't, with the PIs, this is what we have tested, mainly because we have a PI-resistant cell line, and we were trying to see whether KTX can resensitize this particular cell line. But at the moment, we are also trying to see the other drugs, including like BCMA targeting and all the drugs, like whether there is a similar synergy and whether that is cell adhesion mediated as well. So yeah, we'll be exploring.
And then I also wanted to ask about the effects of the immune microenvironments, whether or not you tested with other stromal cell lines as well to see if that changes things.
That is an ongoing thing right now. We have started culturing with the HS-Y stromal cells to see whether there's an effect, but it's quite an ongoing thing at the moment. We haven't tried that before. Yeah.
Brilliant. Okay, one last question and we'll finish.
Hi. Are you looking at the residual levels of the FGFR3 as well?
Sorry. Sorry?
Residual levels of the FGFR3, the translocation, if that impacts?
Haven't looked at that yet, but I mean, oh, no, I haven't looked at that yet. Sorry. Yeah.
Thank you.
Okay, so